agree. I think we've
Yeah.
started
So,
recording. I think we can start.
I started,
okay.
doctor.
Okay. Why don't we go ahead and get started? Next slide. Okay. This is actually a little bit dated information, but it's pretty reasonably close. This is about 10 years back, but I think the data hasn't really changed a whole lot. This is in the U.S. Okay, we see about 1 million injuries per year. Now, in places like India, we see a lot more, and deaths per year we see a lot more. Simply because a lot of these patients don't make it to hospitals and get treated as needed. So that gets to be the real issue. And the other thing is you notice the cost issue is huge. Same thing in India. I mean, it's a big time cost issue, and you know a lot of these morbidities and mortalities that we see with burns are unfortunately with children. And it's the number one cause of death in children under age 14. So you can understand the enormity of the burn problem. Next slide. But on the good side, we've actually gotten better at managing burn patients. About 40 to 50 years ago, we used to have a LD means mortality rate effectively for if you have a 50% total body surface area burn. Um, your mortality used to be about you know 80 it was survival, I'm sorry, survival was about 30%, so 30 out of 100 people would survive. As of early 2000, we're at about 80% of these people survive, so we've actually gotten better, and we've gotten better at managing these patients, and our thought processes have gotten better. But again, the quality of burn care is no longer about patient survival. It's about long-term function, long-term appearance. How can we get them back to a normal life is really the issue. Next slide. So again, most severe burns can be very morbid. They can be, you can save their life, but you end up leaving them in a disfigured state unless you're smart about how you're putting the pieces together. And really, your plastic surgeons and general surgeons are your best friends as far as this is concerned. And the more you utilize them aggressively as ICU teams go, if you can convince your general surgeons that, hey, we work on this patient, you do your thing, bring the patient back to the ICU, we'll take care of the patient, make sure that the patient is able to tolerate the next staged operation. So as you work through this, this is a interaction between ICU and operating teams. So good communication is probably the most important thing that you're going to experience in this area. You really want, and I can't tell you the number of times you make a phone call to a general surgeon or a plastic surgeon that helps you with the burns. Let me tell you, they appreciate the phone call, and your ability to help manage the patient really goes up, and it really gets a lot better. The hyper the hypermetabolism that occurs with burns can be diminished by a good aggressive surgical team. So it comes to a lot, and we'll go over this as we go. Next slide. And again, In children, we see a lot of scald burns. In older children, we see flame-related burns. Adults, oftentimes it's house fires, flammable accelerants, smoking, alcohol-related issues. This is not just in the U.S., but in India as well. You see electrical burns, chemical burns from factories and so forth when they're at work, molten metals at work-related areas. So again, you can see a lot of these, and we'll talk about each of these as we go. But I want you guys to understand the different types of burns that are there. Next slide. And burns are the fourth most common type of trauma worldwide. Now, I don't want to refer them as trauma, but they fall under the general category of injury. Okay, and about 11 million people in 2004, sought medical care for burns. Now, that having been said, that number is probably an underestimation of the number of people that suffered burns. And a lot of them don't come to you until late, when they have other infections and so forth. So you also need to keep that in mind, okay? The lower socioeconomic status, and 90% of burns occur in low and middle income countries like India. So again, safety issues, very simple issues like when petrol is being sold, turn off that engine. People don't think about that, and these are kind of things that if they're enforced, you can prevent a lot of burn situations from occurring. And again, death rates rise with increasing size of burn, the depth of burn, older age of patients, and most importantly, smoke inhalation. One of the big areas that we started educating a lot of our ICU personnel on was, if you see smoke inhalation, if they're coughing up carbonaceous sputum, think about getting that airway intubated early. Don't wait, because if you wait, by the time that airway starts closing down, you won't be able to intubate, and you won't even be able to do a surgical airway because it'll close down all the way down to the thoracic inlet. And because of that, you're not going to be able to protect that person's airway if you don't get them intubated early. So for a lot of our ER docs, what we tell them is if you suspect it, if you suspect any inhalational injury, intubate that patient and ask questions later. If you suspect that there was an indoor fire, a closed space, it was, and any time you think about it, if you're concerned about it, intubate the patient. Don't wait. They'll be saturating okay until they crash, and that's the important thing. And the pulse oxes don't work, because pulse ox, carbon monoxide, will register like oxygen. So the only way you're going to know whether they have true smoke inhalation is if you start getting blood gases. So you really got to be thinking about it. Next slide. And again, outcomes are related to the injury severity, individual characteristics. And here's the thing about individual characteristics. If the patient has comorbidities like COPD, the mortality rates go significantly higher in patients that have comorbidities. So if they're diabetic, their mortality is higher. If they have a history of coronary artery disease, their mortality is higher. So you have to be on the ball. Watch, have an index of suspicion. If you need to be more aggressive early on, do so. Okay, there is nothing wrong, and we've done this plenty of times where we intubate a patient that we suspect has closed space burn with possible inhalational injury. Then, after 2 days or so, we extubate the patient. No problem. If there's no airway injury. If there is airway injury, then we've done the right thing. We've protected the patient. So think along those lines. It's very important that you guys think that way. The other thing is remember, it's not about how good a doctor you have at your institution, but it's resource allocation. It's the ability to communicate between the surgical team and the ICU team. And I'm gonna, I hope, Dilip, you don't get upset, but I'm gonna keep saying this over and over again. Your biggest friend in the world is your cell phone connection to your buddy at the bedside. For the care team, this is it. And for the bedside team, your buddy in the care unit is your best friend on that cell phone. Because I will tell you this, the more communication you can do, the better your outcomes are going to be. And there's no question about it. And aftercare support. Now, once the patient gets sent home, please understand they need follow-up. They need to come back because they're going to be, a lot of these cases, they're going to need multiple surgeries after the fact that they get sent home. Now, those patients need to be followed up, okay? Because otherwise they'll be left disfigured. And it's a big problem. And that's why burn centers have been established to do this, because you really need that coordinated care. Now, when they come back for their surgery, guess what? They need your help as well. Are susceptible to into ARDS, they're susceptible to having additional lung injury. These patients, you're going to have to be back involved when they come back for surgery. So even though they're having what's seemingly okay surgery, they are at higher risk to end up in your ICU with additional comorbid conditions like pneumonia and so forth, more likely than the general population which hasn't suffered a burn injury. So again, that's something to keep in mind. Next slide. These are tough patients, and again, the depth of injury is related to the temperature applied and the duration of contact. Let me put this in context. McDonald's. You guys all go to McDonald's to get your cup of coffee. The cup of coffee that they serve at McDonald's is 10 degrees hotter than other places, other restaurants and stuff, because they want you to have a nice hot cup of coffee. That's how they market it. But what happens is that 10 degrees hotter causes a much more significant amount of injury over a shorter period of time. The classic example was in the U.S., there was a lawsuit that some little old lady was going through the drive-thru, got her coffee, put the coffee cup between her legs. The coffee spilled onto her leg, and she ended up getting a significant burn of her thighs. And she sued McDonald's because McDonald's didn't say that their coffee was 10 degrees hotter than everybody else. Now, in the U.S., that works out. But the important thing for you guys to remember is the hotter the issue, okay, the more and the longer it's touching the skin, the greater the incidence of more significant burn. The other part of this is the thickness of the skin also counts. Now, certain areas of skin, like your back, are very thick, if you recall from your anatomy classes and stuff. But, areas like hands and stuff, they may not be. So it depends on the skin and the thickness of the skin. So consider that. Next slide. And like I said, with scald burns, you really have to be cognizant of how hot the water was. And this is where, one of the preventative measures that we started looking into was the geysers, that heat up the temperature of the water can be adjusted as far as their temperature is concerned. And perhaps not getting the geyser temperature so high is not a bad idea, because I will tell you this, one of the areas that we started seeing a lot was the boilers. If we could turn down the temperature, the amount of the significance of the burns went down. So again, something to keep in mind as far as these are concerned. Now, if children have burns, especially bilateral, okay, remember, if you put your foot into a hot boiling water, or if you put your hand into hot boil, what's your first response? Pull it back, right? Children, if they have bilateral lower extremity burns, guess what? You got to think about child abuse. So these are the kind of things that you have to think along the lines of. Next slide. And again, flame burns are the second most common mechanism of thermal injury. Clothes. Now, here's the other thing when they come into your emergency department, and a lot of emergency docs don't cut the clothes off. You got to cut the clothes off, okay? If they're smoldering, they may still be burning. So you got to cut the clothes off. Get the clothes off and get the patient covered. Now, simply getting the clothes off is not good enough, because they'll go hypothermic. Remember, the skin protects temperature, right? It helps you maintain your body temperature at a constant level, right? Now, if you burn the skin, guess what? You can't. So the emergency room has to be at an uncomfortably hot temperature for the patient not to become hypothermic. So you have to think along those lines, and you have to think about that. And the ICU, the same thing, okay? When the patient has significant burn, that ICU room has to be heated up to a temperature that's uncomfortable. You'll be sweating. Every time you go in there, you'll be sweating. That's the way it has to be. You can't have a nicely air-conditioned ICU room, because your patient will go hypothermic. So that's a problem. Next slide. Flash burns are interesting because they're the third most common, but it's intense heat for a short period of time. The key with flash burns is they're usually associated with explosions. When people tell me a history of explosion happening and the person getting burned, I'm not worried about the burn. I'm worried about the trauma related to the explosion, like a ruptured spleen or a ruptured liver or something of that nature. So I'm more worried about that. If you have an explosion, trust me, your lungs are going to get contused. All these things are going to happen that you have to deal with. So your thought process has to go to that first as a primary issue, and then come back. Now, flash burns will also have upper airway damage. Unburned fuels will get into the airway and continue their burning process. This is a problem, okay, obviously. And what you need to do is get that patient intubated, get a bronchoscope down that patient's airway, and get that airway washed out. The other thing that you have to do in these patients is, I know, I can't emphasize the albuterol, the ipratropium, and the budesonide inhaled. All these have to be put on all your patients that are burn patients, okay? Because I will tell you this, you want to offload the work of breathing as much as possible in these patients. And airway is one of the biggest ways you can do that. So again, something to keep in mind. Next slide. The skin, again, I don't have to tell you guys, the largest organ of the body, 16% of total body weight. The anatomic function is to maintain temperature, to protect you from outside forces, right? And outside bacteria, okay? Now, if you, let's say your patient has burns over the anticubitals. Well, if you need access to vessels, get in through burn tissue if you have to. But remember this, you can't use adhesive tape to tape down the intravenous. So you're going to have to figure out how to use a bandage to wrap around the forearm so that you can secure the IV that way. The other thing is that if I would prefer if you could go through unburned skin. But if you need to get in through burned skin, you can do that. But remember this, 24 hours, you got to get it out of there, okay? You can't go through burned tissue and not expect an infection to set in. So that's important to keep in mind. Next slide. Care at the scene. Let's go. Next slide. And this is where we teach our ED docs as well as our emergency medical personnel that if, stop the burning process. Sounds kind of obvious, but if there's smoldering clothing, A, either get the clothing off, or B, water it down, okay? If it's a chemical burn, please, please, please tell everybody, do not try to neutralize the chemical burn, okay? Oh, we have an acid burn. If we use some base, it'll work. No, it won't, okay? The solution to pollution is dilution. So you have to irrigate, 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 irrigate. Now, but you got to use warm water. You can't use cold water. If you use cold water, the patient will go hypothermic. Okay, so the onus is upon you as the overseeing physician or overseeing nurse to remind our bedside team that, hey guys, watch out for hypothermia. Watch out for this. Watch out for that. You're the guiding eye in the sky, if you will. And this is where it really comes to help. Now, here's the other thing. If they've got jewelry on, in India, our guys wear a lot of jewelry, rings on the fingers, stuff on the wrists. Let me tell you, anything that's on the wrist, that's on the fingers, that's on the toes, that's on the legs, cut it off. If it's around the neck, cut it off, because you won't be able to get it off afterwards because it's going to dig right into the skin. Get it off, okay? Once you can get all that off, then, because the swelling begins immediately, burned skin swells, okay? When it swells, it's going to cut off circulation. So please, okay, make sure you do that. The other thing is if you got extremity burns, what I want you to pay attention to is check the pulse, put pulse ox on the tip of the fingers in multiple areas. The reason is if you're getting a cutoff of flow, the tracing on the pulse ox will go away. Okay? I'm not concerned about the oxygen saturation reading. I'm concerned about the tracing. That's a nice, easy way, the old trick to use to see whether you've got pulsatile flow coming down the extremity. If you don't, think about getting that surgical team to do an eschorotomy, and we'll talk about the eschorotomies in just a second. Again, cold water only for small burns, not bigger burns. Next slide. And by the way, if you have a patient that blisters, and this is the same rule for burns, if they're blistered, all right, if the blister size is more than 1.5 centimeters to 2 centimeters, take away the blister, because it's going to pop on its own and it's going to get infected. Tell the surgical team, take away the blister, clean everything up, and then put topical antibiotics. Now, topical antibiotics, we used to use a lot of silver sulfadiazine. We don't use silver sulfadiazine anymore because in a lot of patients, what we found is that they become leukopenic. So one of the areas that, and it's been studied pretty well, silver sulfadiazine really is not the antibiotic of choice for burns anymore. It's bacitracin. We use, triple antibiotic ointment, and triple antibiotic ointment or bacitracin is available. Smear it on. It's Vaseline based, so it'll stay. And if you got third-degree burns, you're not going to be able to use bacitracin because it won't penetrate. But if you got second-degree burns with blisters and stuff, you take down the blisters and you put the bacitracin. Tell them to apply it liberally, because you're not going to keep the patient on IV antibiotics. Please understand this. IV antibiotics are useless in burn patients, okay? Unless you've got proven infection. And we'll talk about infection in just a second, but we're not there yet, okay? So you want a history of the accident. You want to know what exactly happened, what treatment was given elsewhere or outside, right? And what treatment was given in the emergency department, because that's going to predicate how much fluid you're going to give this patient. Please understand, burns were the first group of guys, and this is why I have so much respect for them. We used to have, when I'm dating myself, but in the 1980s and 1990s, when we were resuscitating trauma patients and burn patients, we would go, the term was hog wild, giving fluid. So we would be just pouring fluid into these patients. And what we ended up doing was ended up killing a lot more patients than we really should have, okay? Because we were just flooding their lungs and flooding every part of them. Not a good idea. These guys were the burn guys were the first guys that actually understood and said, hey, after, the first little while, the first 5-6 hours, back off. Don't go wild with your fluid resuscitation. Watch the urine output. And they were the first guys that said, if you've got 0.5 ml per kilo per hour that's being produced by the patient, that's enough. If they're up to 0.6 or 0.7 or 0.8 or 1 ml per kilo per hour, guess what? You're overhydrating them. Back off. You can use urine output as an indicator of intravascular volume status in both directions, not just, not enough urine output, but in both ways. So this is kind of good physiologic thinking, and let me tell you, we learned so much from this. Next slide. Okay, so initial management. What do we do with burn patients? Same thing as trauma, okay? Airway, breathing, circulation. Now, here's the rule. If you have trauma and burn takes a back seat. That is, you don't treat the burn first. What you do is you take care of the trauma first. Now, the one area that's a concern and that should be on the top of your hit list is if I've got smoke inhalation or a closed space burn, I'm going to have to intubate the patient, which means I've got to take care of the airway a little bit more aggressively than I do in trauma. Okay, that airway has to be intubated. The patient's talking to you, the patient's, I don't care. Okay, they're maintaining their saturation. I don't care, because they're going to lose that airway, and as soon as they lose that airway, you're not going to be able to get it back. By the time they get stridorous, okay, that is the inhalational component of what you're listening to, right? Once you start hearing that inspiratory sounds, it's too late, because trying to get them intubated at that point becomes scary as heck, okay? So please, 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 if you suspect it, intubate the patient, okay? If you're concerned, intubate the patient, okay? We can sort things out after that. But get the patient intubated. Protect that airway. Okay? Once the airway is protected, have a nice day. I can do all my other things with a lot less headache and tension in the room. Okay, if I've got a over 25% total body surface area burn, congratulations, that patient's going to get tubed. Okay, because you're not taking any chances. Okay, there may be inhalational injury, there may not be. You don't want to take a chance. That's the last thing you want to do. Okay, especially for the patient, because it's for the patient's sake here. Okay, because you'll lose that patient, and that's the worry. Next slide. Everybody who has a burn gets oxygen. Okay, and supplemental oxygen is one of those things that, people say, well, the patient has COPD, they're going to stop breathing. I don't care. They need supplemental oxygen. All burn patients will have some degree of carbon monoxide poisoning. You gotta get oxygen on them, and don't worry about this 92, 95% saturation on the pulse ox. Get the oxygen on board and get it running. Okay. If you got smoke inhalational injury, intubate the patient. Okay. But it's important that oxygen be on board, because that's the only real treatment that we're going to provide for these patients that have carbon monoxide poisoning. Okay. So understand that. Next slide. We'll talk about carbon monoxide in a little bit. Next slide. Okay. Now, a lot of patients with burn injuries that are relatively small don't require intubation. Very true. Okay. But if they have larger, deeper burns or burns to the face, if you suspect smoke inhalation, get those patients intubated. If they have deep burns, more than 30 to 40% of the total body surface area, congratulations, intubate that patient. Okay. And, I use the expression at the drop of a hat. If you suspect it, intubate the patient at the drop of a hat. Okay. Do not wait. Do not pass go. Do not collect $200 for those of Monopoly fame. So again, very important to think about. Okay, next slide. All right. Is the intubation required to prevent airway obstruction? And the answer is yes. Okay. You don't want that airway swelling up and closing down before you can get there. Okay. And that's the issue. Okay. If in doubt, intubate. All right. If they have burns over 40% total body surface area, congratulations, intubate. Burns to the head or mouth, intubate. If they had carbonaceous sputum, if they're coughing up anything that's like, soot, intubate. If there was a delay in getting transferred to you and there's a history of closed space burn, intubate the patient. If they have altered level of consciousness, intubate the patient. If they're hoarse, if their voice sounds hoarse, intubate the patient. Don't wait, please. Okay, next slide. Okay, if the patient is conscious, no airway problems, no deep facial problems, you can put them on 100% oxygen by face mask, but obtain an ABG, because remember, carboxyhemoglobin, which comes from carbon monoxide inhalation, is going to read high on the pulse ox. So the pulse ox may read 100% saturation. The problem is, if you look at the PaO2 on the ABG, it'll be registering low. So you gotta watch out. Okay, it's very important. And in fact, the carbon monoxide has a greater affinity for hemoglobin than oxygen does. So it's a problem. That's why we go to 100% oxygen by mask. Next slide. Okay. Does the patient have carbon monoxide poisoning is the next question. Okay. What are indicators? Well, elevated carboxyhemoglobin level, persistent metabolic acidosis. You're going to be on 100% oxygen until carbon monoxide poisoning is ruled out. Okay. The biggest reason why people die with closed space burns is carbon monoxide poisoning. Okay. That's the biggest reason. You hear the horror stories of, a garage where, they left the engine on and they fell asleep in the car and they ended up dying. That is carbon monoxide poisoning. Okay. So again, if there are indicators of smoke inhalational injury, get the patient intubated, do bronchoscopic evaluation, get your pulmonologist or your intensivist at bedside to stick a bronchoscope down. Okay. And that means your endotracheal tube has to be size 7.5 or bigger. Okay. Don't let the bedside team put in a smaller size endotracheal tube because you can't get a bronchoscope through a size less than 7.5. Okay, so you really want at least a 7.5 in the issue. If you can get an 8, that would be great. 7.5 is the minimum size you want. So make sure when they're intubating that they get a larger size endotracheal tube in. Okay, these are important logistical details that the ground team may not be thinking of. You have to remind the bedside team, the bedside part of the component of our team. You have to say, "Hey guys, make sure we're using at least a 7.5 endotracheal tube, so that when we have to go to bronchoscope, we can do it. Otherwise, an adult bronchoscope won't fit in anything smaller than a 7.5 or a 7. It won't fit. Okay, you're going to have a heck of a time. You can use a pediatric bronchoscope, but even there, if you get down to 6.5, you may not be able to get down. So understand that. Okay, next slide. Okay, so again, inhalational injuries associated with 50% of burn-related deaths. Okay, it doubles the mortality rate of your burn patients. Okay, and carbon monoxide is the issue. We'll talk about that. Talk about upper airway burns. We'll talk about lower airway burns. We'll talk about diagnostic issues, treatment issues, and the biggest killer of these patients is necrotizing pneumonia. Okay, because that burning goes all the way down to the respiratory epithelium, the alveoli. And when it does that, that gets to be a real problem. Okay. And unfortunately, when we intubate somebody and put somebody, they're going to be on oxygen. So the burning process will continue all the way down, and that gets to be the issue. So you really have to watch. Okay. And the other thing is when you're bronchoscoping these patients, please, please, please make sure that you give them bronchodilators. Lots of bronchodilators, okay? Because you'll watch as they're doing the bronchoscopy, as you're doing the bronchoscopy in these patients, and I've done this, that you can see the bronchial spasming. And you're going, oh my gosh, oh my gosh, oh my gosh. Okay. These are scary patients, okay? Because, they start desatting as you're doing the bronchoscopy. Then you got to, bag them back up and then wait, let them saturate, let them ventilate, and then go back in again to have another look and wash out the soot. So washing out the soot becomes very challenging. So that gets to be the issue. Next slide. Yeah, Rolly.
Sir, regarding this, when we are giving bronchodilators, a common practice in our country is that everyone who gets a Duolin also gets a budesonide nebulization. Or if during the bronchoscopy the patient is having spasm, steroids. If you could just highlight on those things.
Yeah, I mean, and everybody should be on budesonide. Everybody should be on albuterol. Everybody should be on ipratropium. The other thing is if you want to give a dose of glucocorticoids, either
Mhm.
hydrocortisone or any of the glucocorticoids, if you want to give that while you're doing this, go ahead. It's not a problem. Short-term use of glucocorticoids is not an issue as far as infectious risk or wound healing risk. So you can use short-term low-dose steroids, and anything under a couple hundred milligrams, in a 24-hour period is considered low dose. So don't worry. Okay, just go
Okay.
ahead and give. Okay. Um, Carbon monoxide, for those of you that are unfamiliar, it's colorless, odorless, tasteless, and its affinity for hemoglobin is 200 times that of oxygen. Um, Now, typically, carbon monoxide stays on the hemoglobin on 100% oxygen is about 40 to 60 minutes. I usually like to keep patients on 100% oxygen for about one shift, usually 8 hours. Okay. I'll leave them on that just so that I'm covering all my bases. Um, if they have mental status changes and you have hyperbaric oxygen available, yeah, okay, you can think about it. But hyperbaric oxygen is an extra step that we typically don't use. And most of the centers where I've worked, we didn't have it available, so it doesn't matter. 100% oxygen is really good. I mean, that's the way to go. Okay. Next slide. Okay. And again, if it's elevated, carboxyhemoglobin is elevated, keep the patient on 100% or 90% oxygen until the carboxyhemoglobin level drops below 7%. Use positive pressure ventilation if the carboxyhemoglobin level is greater than 40%. So again, and hyperbaric oxygen is reserved for the kitchen sink cases, where you're kind of just throwing everything at the patient. You can, and and even things like ECMO and stuff have been thrown at these patients. Like I said, there's not enough data for us to really say much about that. Okay, next slide. But once you get the kitchen sink, you're pretty much done anyway. So, what's our treatment for smoke exposure? Aggressive pulmonary toilet. Watch the close monitoring of gas exchange, lots of ABGs or BBGs, so that you're monitoring this. Controlled fluid treatment. Do not flood the patient. Okay. Watch your ID. Now, we're going to go over the Parkland formula and the Brook formula, but here's the thing. Okay. Those are starting points. They're not the end all serve all. Okay. So please, please, please don't think that, if the patient's urine output is over 0.5 ml per kilo per minute or per hour, stop, slow down. Don't have to overtreat. Okay. Assess that airway. What's going on. Listen. And here's the other thing. There's another trick here. Okay. If you listen in an intubated patient from the front, you're listening to lung zones 1 and 2, right? Not the real workhorse, right? The workhorse is the lower lobe. So if you listen from the sides or the back, you're listening to the lower lobes. Now, if you're hearing a difference between the lower lobe sounds and the upper lobe or middle lobe sounds, then what that tells you is you have reserve. If they don't sound the same, if they sound different, you've got room to maneuver as far as your ventilator is concerned. If they sound exactly the same, you may be running out of reserve. Okay, your body's using, the zone 1 and zone 2, which is anterior and up. Okay, those areas as the reserve, if you will, a reserve fuel tank. Okay. The lower lobe is the workhorse. So this is what you need to listen for. If you're hearing inspiratory sounds, you're getting secretions. Get those secretions out. If you're hearing expiratory sounds, it's bronchiolar level and lower, and that is pharmacologically managed. That means if your bronchodilator is every 6 hours, you may have to go to every 4 hours or even every 2 hours. You may have to use a long-acting agonist, bronchial dilating beta agonist. So you may need to go to LABAs, okay, long-acting beta agonists. So you may need to go to that. So you have to think about more aggressive means to address the bronchiolar areas, okay? So you really got to think about it. And if the patient has gotten into a severe bronchospasm and you can't break it, okay, there's another trick. Transport the patient or transport the operating room inhalational anesthetic machine over to the patient and use the inhalational anesthetics to bronchodilate your patient. I've broken bronchospasms that way a few times, okay? And it works. It's what I use for status asthmaticus, but I also have used it in burns, where a really tight bronchospasm takes over and you can't break it. That's the trick. Inhalational anesthetics do an amazing job. So think about that. Okay. So again, next slide. If I got a facial burn, okay, think about an acute airway problem, okay? If the face is burnt, you've got an acute airway problem, okay? I don't care if it was a geyser burn, where liquid scalding hot water fell on the face, or it was a flame burn, somebody fell asleep with a cigarette in their mouth. It sounds kind of stupid, but, people do the craziest things, and I can't make this stuff up. This is real. I mean, I've had patients like this. The guy fell asleep in bed with a cigarette in his mouth. His sheets caught fire, and he got burnt, and he came into my ER and in my ICU. So you could see how this happens. Again, CPAP and PEEP start at 5 millimeters of mercury. And again, assess the airways. Get the patient intubated, put a bronchoscope down. You don't need volume control ventilation. You can put them on pressure support ventilation because they're able to breathe on their own. It's not that they can't breathe on their own. It's that they can't control their airway, and that's the issue. So if you want to leave them on a CPAP modality, it's not a problem. Just make sure you're checking blood gases. Watch what they're doing. But, your machines, most of the ventilators, Dilip and everybody else can clarify, but I can tell you there's a default. So if the patient goes apneic for any reason, the machine will default to an SIMV of 6. At least I think it used to. I don't know if they still do or not. But there is a default modality in most of these mechanical ventilators. So that's something to keep in mind. And again, you initiate standard treatment for smoke inhalation, which means you get them suctioned, irrigate, suction, irrigate. Now I know saline irrigation for pneumonia patients and so forth has not been shown to improve outcomes and all that. In burn patients, if it can get the soot out, trust me, the severity of the ARDS that you see will be much less. Now, here's the other thing to remember. If you're scoping or if you're suctioning these patients, if you stick an endotracheal suction catheter down the airway, all right, 70% of the time, which side are you going to go down? Anybody?
Right side.
Right side. Absolutely. Right? So what do I have to do to get down the left? It's simple. Turn the neck. If you turn the neck to the right, you can go down the left. If you turn the neck to the left, you go down the right. Or if you just put it in neutral, you go down the right about 70% of the time. This is the trick to remember. If you want to get down the left, turn the head to the right. So it's a two-man or two-person process, okay? One person can't do it. You got to do it. It's a two-person thing, all right? Most endotracheal suction, you need two people to do it right, okay? So again, two people, all right? So think about it that way. There's no role for steroids. Please remember this, okay? No role. No role for prophylactic antibiotics, okay? And here's the thing. I know it's really hard. In India, to stop antibiotics is like trying to stop the rain, okay? It's really hard. I know it, okay? But you got to tell the bedside team, no antibiotics, okay? Do not give antibiotics, because I will tell you, I can guarantee you a patient with soot in their airway is going to develop a pneumonia. No question, okay? However, if you start antibiotics, the first infection that you see is going to be a multi-drug resistant infection, and the second infection that you see is going to be a totally multi-drug resistant infection, and you're going to be screwed, okay? So remind everybody, okay? Don't treat early on. Wait. Once the airway secretions start turning a tan color, that's when you start. Okay, that's when you need antibiotics. Okay, delete.
Yeah, just before we move on from the airway, I just wanted to make two quick comments. One is that you can put the patient on CPAP, and like you said, there will be a backup. But when you're doing bronchoscopy, just switch them to volume control or pressure control with a fixed inspiratory time. Because if you do a bronchoscopy on CPAP, it's going to be a little bit of a disaster. So
yeah, it's a problem. You're right. You're
so
absolutely right.
yeah, that's one comment. And the second one was that when you're doing a bronchoscopy on a burns patient, other than targeted suctioning, try to stay away from the walls, because the more you touch the walls when it's not needed to be touched, you will trigger a bronchospasm, just like you were mentioning, and those can be very hard. So it should not just be in and out a random bronchoscopy. You got to do it carefully. Touch the walls only when you need to, if you're trying to remove something, because these are hyper responsive airways that have been irritated by burns, soot, all sorts of chemicals that have gone there. So you want to be very gentle when you're doing bronchoscopy with these patients. So just these two comments.
Absolutely. And Sanat, your comment about pressure control, whether you use pressure control or volume control, I will tell you this, your alarms on the ventilator are going to be going off as you're doing the bronch. So understand that. In, out, quickly, but in an organized way. Make sure that you're going, toward in a stepwise manner, just like you guys do bronchoscopy in a specific way. Remember, the airway pressures, fixed inspiratory time, but the airway pressures will shoot up because your bronchoscope is blocking the airway. I mean, this is this is something that it's a occupational hazard, if you will. So because of that, you have that issue. The other issue is when you're irrigating and so forth, remember, you can get into, they will spasm on you. And as you're watching, if they have significant airway burn, they are going to be spasming as you're doing this. So you're going to have to take your time, go in, come out, let the spasm break, come back, do it again. So this is how you're going to have to, and make notation of where you were so that you don't go back and just go to the areas where you've been. Go to all the areas so you can check out the areas that have been burnt, so you can document where the burns are. Because I will tell you this, the areas where the soot is the greatest concentration, that's where you're going to see the pneumonias. The necrotizing pneumonias are going to be in those areas. And usually those are the most dependent areas, right? The right middle lobe, usually, the right lower lobe, usually, the left lingular segments and the left lower lobes. The upper lobes are usually spared. But then again, if you're completely supine for a while, you may or may not be spared for the next round of pneumonia. So something to keep in mind. Next slide. Again, inadequate ventilation. Think about bronchodilators. Initiate standard treatment for smoke exposure. And rule out restrictive problems. That is, if you got chest wall burns, get the surgeons to open up the chest wall, do an escharotomy, and they'll know how. Just get them to do it, okay? You may need to increase PEEP. You may need to do that to increase your mean airway pressure to get adequate ventilation. You may need to do that, but think about an escharotomy. Remember, your backside is always non-compliant, right, in the chest. The front is the compliant portion of the chest. If they have significant burns to the front part of the chest, you don't need circumferential burns. All you need is burns to the front part of the chest, and if you have that, you can have enough restrictive component that they may not be able to ventilate. So you have to keep that in mind, okay? Again, very important thought processes. Next slide. And you can see how the facial edema will go from looks okay to, oh my God, how are we going to intubate that? So please, please, please think, if you have a facial burn, think about getting that patient intubated. And we'll pull up here. Any questions? We'll finish
No
up
questions from my side.
the next round. Good, good.
Yeah, fantastic
Well,
talk. I mean, really high impact. I think that point about when and whom to intubate and how quickly to intubate is critical. So I think that should be
absolutely,
like a
absolutely.
top level slide right
Yeah,
there.
and don't feel bad about intubating a patient and them not having much airway issues. That's great. I'm the happiest guy in the world if you've intubated somebody, protected their airway, and found that there's no airway burn. That's great. You can extubate the patient the next day. It's easy enough to do. But the key here is you've ruled out airway burn. So that's what's important. Okay. All right. So
I have only
we'll pick up.
would you be
Yeah, Shashi.
doing I mean, patients once they're intubated, and in terms of having resources, would you be touching upon transport as well?
Well, I think if they're intubated, I mean you're gonna have to. I mean, there's no option there. So you're gonna have to really kind of think about how you're gonna manage the patient and get the patient. And if you don't have the resources, then it becomes a problem. You're gonna have to have them bagged. That's the only thing you can do.
The other reason is, I mean, not all places a bronchoscopy is easy access. It may be so.
I agree. In that setting, the recommendation that I would have is have the bedside team do endotracheal suctioning, see if they can get down both sides, see what they have, what's coming up. Is it soot filled, or is it is it clean? If it looks clean, then yeah, it's okay. If it's soot filled, then you've got airway burn, and you're going to have to be thinking that you're not going to be able to extubate the patient anytime soon. Sanat.
Based on what do we decide who needs bronchoscopy?
Usually, if you intubate somebody with a burn, you're gonna put a bronchoscope down to rule out airway burns. Whether you have upper airway burns or lower airway burns, pretty much everybody needs a scope. Now, if you can't get a scope or you don't have a scope, in that setting, my suggestion would be have the bedside team squirt 5 ml of saline down, bag the patients, endotracheally suction them, and see what's coming up. based on what's coming up, you'll at least have an idea whether you have an upper airway burn. And then once you have an upper airway burn, then you assume that you have a lower airway burn as well, and you're going to have to manage accordingly. Now, the other thing is when you go to extubate these patients, I love the leak test, and the leak test is where you deflate the balloon on the endotracheal tube, and you get air coming around the outside of the endotracheal tube. If you don't get that leak, that means that the trachea is still swollen and you can't extubate the patient. You got to wait. If the leak test is telling you that there's no leak, then you got to be concerned that that edema in the trachea is still there and it's a big problem. So, this is where the leak test is very helpful. Any other questions? All right, guys, we'll finish up at the next session. All right.
Take care.
Have
Bye.
a good day. Have a
Thank you
good
very
day.
much.
Thank
All
you,
right.
Dr. Chandrashekar.